The retrograde approach to the femur is chosen when the fracture is near the distal end of the femur. There may be anesthetic reasons for using a retrograde approach to the femur because the patient is supine. If the patient has a lung injury or a head injury, many times the anesthesiologist will prefer the supine position. In that case, fractures as high as in the proximal third can be done, and I've seen many segmental fractures treated with retrograde approach where the second fracture is next to the lesser trochanter. Once you've decided to use the retrograde approach, test flexion and extension of the knee. You need 60 degrees of flexion to insert the nail and the reamers. If you don't have 60 degrees of flexion, you can attempt manipulation of the knee under anesthetic. Sometimes it's very difficult to manipulate the knee to 60 degrees, and in one instance I made an incision in the patella tendon and removed the medial 1/3 of the patella tendon. It's left attached at the patella and sutured back to the tibial tubercle later at the end of the procedure. Once you have your incision through the patella tendon, and I would tell you that making the incision through the patella tendon is a lot easier if you can do this in maximal flexion because you can feel the patella tendon. Some people go medial to the patella tendon, and that's perfectly acceptable because the entrance hole is going to be in the medial side of the femoral groove. Once the incision has been made, you must make a window through the fat pad. I use a knife and a pickups to do this, and some people use a cutting cautery. Once the hole or window is made in the fat pad, you can visualize the femoral notch. Flex and extend the knee in order to get better visualization of the femoral notch. The bony entrance for the reaming and insertion of the nail is on the medial side of the femoral groove. This is more in the center, but it's on the medial side of the femoral groove. Sometimes when I can't see the femoral groove well, I make an indent with the alignment pin and feel the indent and then use the curved awl to make the bone entrance.
Here's the curved awl.
Once the bone entrance has been made, and you're going to do a closed reduction, direct your reamers through the metaphysis into the diaphysis. I'm seeing more and more distal femur fractures treated without a C-arm by closed reduction. If you're going to do an open reduction, there are 3 considerations. The one consideration is if there's no intercondylar fracture, the incision is made in the lateral side. Incise through the tensor fasciae lata and use the periosteal elevator to dissect through the fibers of the vastus lateralis, as you did in the antegrade approach to the femur. After reduction is obtained, look carefully at the fracture site to direct the reamers. If there's an intercondylar fracture, a fracture going into the joint, I use the total knee implant incision. This is a straight incision beginning by incising the quadriceps tendon, going over the patella down to the tibial tubercle. Patella tendon is then incised from the patella only about 1/2 and certainly no more, and a medium parapatella incision is used. You can then dislocate the patella laterally and easily reduce the intercondylar fracture. The same incision can be used to fixate the intercondylar fracture and place the nail. You can also use the same incision to place the interlocking screws through the end of the nail nearest to the knee. I'd like to make 2 points about stabilization of the femur through the retrograde approach. The first point is the length of the nail. Ending the nail at the lesser trochanter or 4 centimeters distally may result in fracture of the femur later on if the patient has subsequent trauma. This is the high stress area of the femur. The stress comes from the interlocking holes, and the stress comes from the end of the nail. It's really bad to leave an unfilled hole in this area of the femur. So if you make the nail long enough to bypass this high stress area and end in the greater trochanteric area, that is ideal. If you end the nail below the high stress area, I've never seen a fracture at the end of the nail or at the interlocking holes. The other point I'd like to make is using the ring to determine the depth of the nail. This ring should rest on the articular cartilage. If it rests on the articular cartilage, the nail will be just below the articular cartilage and will be at the ideal depth.